Hi there. I'm Gad Marshall. I'm a behavioral neurologist at Brigham and Women's Hospital, Mass General, in Boston. And I'm here at the AAN. This is Los Angeles, and I'm going to summarize some presentations about Alzheimer's disease clinical trials. So I'm going to start off by discussing a couple of trials that had open-label extensions and results were presented. These were of monoclonal antibodies against amyloid. And so the first one was aducanumab. And this particular drug targets fibrillar amyloid. There was a large phase 1b trial of close to 200 participants for 1 year. This was a double blind. And then now what was reported is the open label extension and the participants who continued to get the drug for sure after completing the double blind for 2 more years. So the findings primarily focused on changes in amyloid burden in the brain. So all participants underwent fluorobeta-peer amyloid PET scans, and what was seen was that, in fact, there was ongoing reduction of amyloid in the brain of these participants, as was seen in the double blind. And this was across different doses, and the response was greater in the higher doses. In addition, there was a clinical signal as well, focusing on global functioning with the CDR, as well as global cognition with the MMSE. And there was a similar signal there showing further improvement, or in fact, I guess, slowing of decline in cognition and global functioning, particularly for the higher doses of this drug. And so this was encouraging, extending the results of the double blind that was 1 year to 2 more years. And there was also a lot of safety information provided. And what was particularly encouraging is that individuals who completed the double blind at 1 year, who were exposed to the drug and then continued for 2 more years on drug, did not have one of the main reactions that's concerning with this drug, ARIA-E, or amyloid-related imaging abnormality edema, or in other words, vasogenic edema or swelling in the brain. And so this particular reaction was noted in about 25% of individuals on drug and double blind. And so this is, of course, concerning, and this was not seen in people previously exposed who continued in the open label extension. It was seen in people who were on placebo and then were exposed to the drug for the first time at similar rates. And so this is ongoing evidence supporting the development of this drug. There is a phase 3 trial, or 2 phase 3 trials of aducanumab internationally that are ongoing and, in fact, almost completed enrollment. And then there will be an 18-month follow-up of those individuals. And so those particular trials continue to mitigate some of these reactions like the ARIA-E by trying to adjust the dose, as well as differential dosing based on ApoE4 status, which has shown to be related to this particular reaction. And so we look forward to seeing those results in the coming years. Another similar monoclonal antibody against amyloid, gantenerumab, which also targets fibrillar amyloid, had a presentation focused again on open label extension data. So there are 2 large phase 3 trials with doses of 105 milligrams and 225 milligrams with this particular drug that were completed, and the results were not so promising. And so open label extension and smaller subsets were designed with a much higher dose of 1,200 milligrams. And in fact, with that particular dose, with a 1 year follow-up, the results were encouraging, showing reduction of amyloid burden, again, with amyloid PET scans. And so this is something encouraging and is now leading to a phase 3 trial that will focus on the high dose and will target people with prodromal and mild Alzheimer's disease dementia. And so this is a similar result to aducanumab, and again with a fibrillar amyloid target, giving us hope that these, in fact, will be biologically active and clinically active when we see the larger phase 3 trials repeated. There was a very novel new drug that was in early stages of development that was discussed as well in a separate presentation. This one targets tau, and it is an antisense oligonucleotide target. And what it does is looking at specifically trying to reduce tau by focusing on the mapped mRNA And this is a known mutation that relates to tau production and has been associated with tauopathies. And so this particular drug is going to reduce tau in the brain, and it was tested in a mouse model showing promising results, reducing the mapped mRNA, also reducing tau burden in the brain, and showing a clinical relevance with extended survival as well as better functioning. And then it was taken forward to primate testing where it was given intrathecally and showed tolerance, adequate tolerance of the drug, as well as another promising signal biologically showing reduction of tau in the brain, primarily in the frontal regions as well as the hippocampus. So what was then presented was the plan for the first-in-human trials. And so this would be a phase 1 trial targeting mild AD dementia. And it will be a double-blind, and it will, again, use this particular drug with intrathecal injection. And we will have individuals exposed to multiple doses to see if, in fact, there is safety and tolerance of this drug in human beings. And then measuring pharmacodynamic properties of the drug, and lastly, some biomarker outcomes looking at CSF and imaging. And so this is a novel approach that's early in development. There are currently several phase 2 trials looking at anti-tau antibodies that are given via infusion as opposed to this intrathecal injection, and we also look forward to seeing the results of those. What I'd like to talk about next is a meeting that occurred during the AAN that was a separate meeting with leaders in Alzheimer's field. And it was the ACTC meeting, or Alzheimer's Clinical Trial Consortium. It was the first meeting of this particular entity that was recently funded by the NIH, specifically the National Institutes on Aging, trying to move us to the next stage of design of Alzheimer's disease drugs, and also support of various academic centers that are leading the field. And so this particular consortium is led by 3 academic centers. So University of Southern California with Dr. Paul Azen, Brigham and Women's Hospital and Massachusetts General Hospital with Dr. Risa Sperling, and then the Mayo Clinic with Dr. Ron Peterson. And 35 member sites are currently included across the U.S. The particular goal of this consortium is to help provide support for these sites, resources, as well as innovative design of clinical trials. And while there is encouragement to partner with pharma for larger trials, there is also a plan to focus on trials that are more proof of concept that would not necessarily be of interest to pharma and would be unique to this type of enterprise. And so this was the first meeting of this particular consortium, and we look forward to seeing a lot more work done by them. And on that note, I will end and hope to see you again next year.
Hi, I'm Liana Apostolova. I'm professor of neurology at Indiana University, and thank you for inviting me to summarize some of the science that was presented at the AAN regarding Alzheimer's disease and other dementias, and also discussions that went on at some satellite meetings that we Alzheimer's researchers often have around the AAN. In the days preceding the AAN, the Alzheimer's Disease Center researchers are meeting together to review the state of the field and to pave the way forward for the next year or years of research. These gatherings usually start by the NIA giving an overview of where things are and what kind of funding opportunities will be available to researchers in the future. And this year, a lot of the discussion revolved surrounding new initiatives that were recently started or major old initiatives that have made significant progress. The discussions were mainly led by Eliezer Maslaya and his colleagues from the NIA. And they summarize findings from initiatives such as the Alzheimer's Disease Sequencing Project, the AMP-AD project, the MOVE-AD project, and several others. The Alzheimer's Disease Sequencing Project has discovered several new variants in the past year. There was a wonderful publication coming out describing new variants that have to do with endoless lysosomal genes, and another one focusing on rare variants such as TREM2. In addition to that, a very big meta-analysis recently was published and was presented at the AAN meeting, focusing on validating the old Alzheimer's disease risk genes, but also coming up with 9 new variants in a cohort of 400,000 individuals. So significant advances have been made to further delineate the heterogeneity of Alzheimer's disease and the heritability of Alzheimer's disease, but still we're not there. Following on these variants, what are the next steps that we as researchers should be doing? And it is studying how they impact the organisms. And by that, I don't just mean the human organisms. So Model AD is a very new initiative that was started by researchers at several laboratories, including Bruce Lamb at Indiana University and also the Jackson Laboratory, that is focusing on inducing Alzheimer's disease risk variants in mice. That is using a new model system called CRISPR to introduce the exact genes or gene variations seen in the human being in these mice models, and then study the deleterious effects that these variants might have and understand better the biology of Alzheimer's disease. We are very fortunate to be collaborating with that group on several additional projects, following through some new genes that were discovered in research in my laboratory and others, specifically ABCA7. During the AAN meeting, some colleagues of mine and myself structured an educational session on the use of neuroimaging for diagnosing dementia. And my colleague, Gil Rabinovich, who is the leader of the IDEA study, presented the latest findings from that fantastic project. The IDEA study started probably a couple of years ago. It's one of the studies that is funded by the Center for Medicare Services. The goal of the project is to ascertain whether imaging with amyloid PET has utility in the clinic. Medicare is the major funder, obviously, of insurance for people age 65 and older. And even though amyloid imaging has been FDA approved, it's really not available for use in clinical settings because funders are not yet reimbursing for this particular methodology. The IDEA study is set out to study what the impact is on diagnostic accuracy and patient management, and what the long-term impact on cost savings are by reducing the rates of hospitalizations or ER visits over the next few years after amyloid PET information is available to the physician and the patient. The study has had tremendous success in recruitment. And they actually closed recruitment a few months early and met their goal of over 18,000 participants. The interim results that were presented focused on the impact of amyloid PET on diagnosis and medical care. In terms of impact on diagnosis, patients with positive amyloid PET scans previously before the PET scan were diagnosed with Alzheimer's disease in about 73% of the cases. And after a positive amyloid PET scan, that diagnostic certainty increased to the point where 95% of the patients were now diagnosed with dementia or mild cognitive impairment due to Alzheimer's disease. On the flip side, in patients who had negative scans, the diagnostic rate of AD declined, appropriately so. They entered the study with 70+% having a preliminary diagnosis of Alzheimer's disease, but at the end, as physicians observed the negative results of the amyloid PET scan, that diagnostic certainty decreased to 14%. Alongside that, of course, management changed. People with positive amyloid scan were more likely to be prescribed or kept on Alzheimer's drugs, while, of course, those with negative scans had some discontinuation of such therapy. I think these are very promising results. They are meeting the goals of AIM 1 of the project. Of course, one needs to wait and see how the full data analysis will come out once all 18,000 patients have been analyzed. But all looks very promising. And of course, we are awaiting data on rates of hospitalizations and rates of ER visits after appropriate diagnosis, counseling, and education of the family and the patients. Here at the AAN, another focus of the meeting was on early diagnosis. And this time, in addition to imaging, which is always center stage, a lot of attention was paid to plasma biomarkers. I was happy to see abstracts from my colleagues at Mayo Clinic and at UCSF presenting data on sensitive plasma proteins that might be potentially useful to diagnose patients with neurodegenerative disorders and Alzheimer's disease. The Mayo Clinic group focused on neurofilament, which is a protein that can be readily measured in CSF, but also in plasma. They presented data that higher neurofilament levels are observed in patients who are cognitively impaired, regardless of amyloid status. So levels were higher both in mild cognitive impairment individuals with positive amyloid PET scan and those without, indicating that is a very sensitive biomarker for neurodegeneration. And also the researchers suggested that it perhaps has also its place in the new Alzheimer's disease framework, the so-called AAN framework, where A stands for amyloid, T stands for tau, and N for neurodegeneration, is one of the more impactful measures other than MRI to suggest neurodegeneration being present. In addition to that, the UCSF group presented data on a very sensitive multi-protein panel measured with Simoa Quanterix that focused on neurofilament again, but also on several other inflammatory markers, on the vascular endothelial growth factor, on BDNF, the brain-derived neurotrophic factor, on the glial astrocytic fibrillary protein. And that panel of proteins was studied in patients with normal cognition, in patients with early onset Alzheimer's disease, in the stages of early and late MCI, and also in vascular dementia. And appropriately so, the researchers found evidence that the vascular growth factors are highest in individuals with vascular dementia, while those suggesting synaptic damage, or those suggesting endothelial dysfunction, or those suggesting astrocytic dysfunction are seen aberrantly abnormal in individuals with cognitive impairment regardless of cause. I was also very pleased to see presentations by the Lefties and Artful groups that focus on research of frontotemporal dementia. These two large initiatives, multi-site studies, will enroll patients with sporadic forms of frontotemporal dementia or hereditary variants of frontotemporal dementia. They presented some data suggesting that they have met their recruitment goals and that the biomarker and cognitive assessment studies are currently ongoing. At our next meetings, we will be seeing results from these major initiatives. That brings me to the topic of new initiatives that are being started. And one of those is the longitudinal early onset Alzheimer's disease study that me and colleagues are about to launch. We just received funding from the NIA to begin this new initiative where we would focus on those individuals with Alzheimer's disease that have been neglected in Alzheimer's disease research. On one side, we have ADNI, which is the most prominent Alzheimer's disease human study to date that focuses on late onset Alzheimer's, those with disease onset at age 65 or later. On the other side, we have the DAAN, the Dominantly Inherited Alzheimer's Network Initiative, focusing on those who have genetic predisposition for Alzheimer's disease through the APP presenilin 1 or presenilin 2 genes. And in between, we have individuals who are between the ages of, say, 30 and 65, who still develop Alzheimer's disease but do not have one of those genetic abnormalities. And these individuals were orphaned. They were not included in clinical trials or any other research studies to date. We're launching a multi-site study across 15 universities and academic centers in the United States, focused on individuals with sporadic early onset Alzheimer's disease, in hope to better ascertain, improve the diagnostic criteria, the evaluations, better understand disease progression. What we know about this group of individuals is that they have a very aggressive form of Alzheimer's, not only because it affects them so early and prematurely, but also they progress at much faster rates compared to those with late onset. We would like to study that, and we would like to also understand better the disease heterogeneity. Many of them present with atypical Alzheimer's variants that oftentimes do not affect memory, but rather affect, say, visual spatial function or the frontal lobes or the language networks, and they're often misdiagnosed. This particular project, we think, will have very strong societal impact. These individuals are still in the workforce, not ready to retire. They're primary breadwinners for their families. They're raising children. And so far, they have been misdiagnosed or not diagnosed accurately and really have not been placed on appropriate therapy. Raising awareness is one of our goals, improving their chances to get accurate diagnosis and eventually treatment is another. And lastly, where we're also going with this particular project is to have developed these clinical sites as a network ready to launch clinical trials in this population. There is also more to discover in this specific population. One has to ask themselves, why are these people getting Alzheimer's at such an early age? What are the risk factors these individuals harbor? And of course, the answer would be environment and genetics. We are going to do whole genome sequencing in these individuals and expand to study DNA from other cohorts, other centers, to be able to more meaningfully and powerfully discover new disease variants. So far, with all the efforts that have been going on with ADSP and other genetic initiatives, we still are only able to explain half of the heritability. A lot of signals are still missing, and we believe that the early onset individuals potentially will help us uncover new genetic risk variants and potentially new treatment targets.